Good afternoon. Today I have the privilege of talking to you about an interesting case in which we utilize myocardial contrast echocardiography in the diagnosis of Takotsubo cardiomyopathy. We have no relevant financial disclosures. So the introduction and objective of this case report is to kind of understand how we can utilize myocardial contrast echocardiography in the diagnosis of Takotsubo cardiomyopathy. So just a brief background, Takotsubo cardiomyopathy is a reversible cardiomyopathy that is usually triggered by an acute stressor. Now, the proposed mechanism behind this cardiomyopathy includes a sympathetic surge of hormones that seems to more or less stun the heart. On echocardiography, there are a variety of different forms that this can kind of present with, but the most common presentation is the basal hyperkinesis with apical hypokinesis, which is that classic apical ballooning, and it's where the name Takotsubo actually comes from, the Japanese octopus pot. Now, apical hypokinesis can obviously mimic left anterior descending artery ischemia, and generally the gold standard to differentiate the two is to perform a coronary angiogram. Now, we describe a case in which we use myocardial contrast echocardiography to help differentiate between Takotsubo cardiomyopathy and left anterior descending artery ischemia. Now, this patient did end up going to the cath lab to help us make that determination, but we did utilize this modality prior to the cath lab. So now what I would like to do is to highlight two cases that help us to differentiate Takotsubo cardiomyopathy from LAD ischemia. So in the first case, we have a 76-year-old female. She's got hypertension, diabetes. She came to an outside hospital with a chief complaint of altered mentation and generalized fatigue, and she had just come back from a cruise for about a week. CT imaging revealed a pneumonia for which she was treated, discharged to a rehab center, but was unfortunately admitted to our hospital after being there for less than 24 hours for hypoxia. Initial EKG was normal sinus rhythm, but her initial EKG at our hospital showed T-wave inversions in V2 to V6 as well as the inferior leads. Her initial troponin was 561 nanograms per liter, which downtrended to 400. When we performed an echocardiogram, it showed akinesis of the mid-distal, septal, anterior, inferior, apical, and periapical walls with hyperdynamic LV basal segments. So we then performed myocardial contrast echocardiography, in which we use microbubbles as tracers, which allows us to visualize blood flow in the myocardium. So we found that there was microbubble uptake throughout the myocardium, suggesting that this was evidence of Takotsubo and not true LAD disease, because in LAD disease, you would not see uptake of microbubbles in the myocardium. So when we took the patient for coronary angiogram, she unfortunately was found to have multivessel disease. However, the lesions were chronic, and it was felt that this did not explain her acute presentation. So thus, our final diagnosis was Takotsubo cardiomyopathy with underlying multivessel disease. And the last case is a 43-year-old female with hypothyroidism presenting after a witnessed cardiac arrest while attending her sister's bridal shower, defibrillated times once, got ROSC, and she presented to our emergency department. Initial EKG was notable for sinus tach, but then had notable T-wave inversions in V1 to V3. Tropes 28 initially, 3000 at the peak. Again, echo showing evidence of hypokinesis of the apical, periapical walls, hyperdynamic LV basal segments. When we did the myocardial contrast imaging, we did not see any uptake of microbubbles in the distal apical wall, which made us suspicious that there might be true LAD ischemia. And when we took her for coronary angiogram, we did in fact find that she had distal 71% LAD lesion concerning for spontaneous coronary artery dissection. So Takotsubo cardiomyopathy is obviously a diagnosis of exclusion, with coronary angiogram being the gold standard to kind of rule in or out the disease. Now, myocardial contrast echocardiography has emerged as a non-invasive method to help differentiate between the two. Now, because Takotsubo cardiomyopathy involves microvascular dysfunction, myocardial contrast echocardiography can be utilized to assess the myocardial perfusion, and obstructive coronary disease, such as seen as in ACS, would result in decreased perfusion. And more studies are needed to be done to see if myocardial contrast echocardiography can be utilized as a non-invasive modality to rule in or out Takotsubo cardiomyopathy. And our personal belief, or my conclusion, is that, myocardial contrast echocardiography, it's an important non-diagnostic imaging modality that can help differentiate Takotsubo from LAD ischemia, and potentially, if enough studies are performed and if it's validated enough, maybe we could potentially avoid having to put our patients through an invasive procedure when the history, the physical, the lab findings all kind of maybe point towards Takotsubo. Thank you.